Thank you very much. Hello, thank you all, and thank you very much for the invitation to speak. I'm Jamie Franklin, I'm a radiologist from Bournemouth, and I'm going to be talking about how we might improve ultrasound surveillance for hepatoma and talk through some of the recommendations we're making as the NHS England Ultrasound Guidance Group. So I'm pleased to say I think this is the first ultrasound image of a liver under surveillance that we've had in this session, and what we really want is for as many patients as possible to be diagnosed with early or very early HCC, which we can offer treatment with curative intent. Just like this patient who came through our HbMDT recently, this small solitary hepatoma picked up by one of our excellent sonographers and offered ablation. So just a little bit of background. We know quite a lot about how ultrasound performs in HCC surveillance. We know it's highly sensitive for asymptomatic HCC at any stage, although it is less sensitive for early HCC, and that's an issue I think we'll come to later in the day. However, overall, HCC surveillance is a good thing. It's associated with improved early detection of hepatoma, increased receipt of curative treatment, and improved overall survival in patients with cirrhosis. So, as we've already heard, on that basis and the basis of prior evidence, despite the lack of RCTs that Tom highlighted, NICE has recommended that we offer 6-monthly ultrasound, and that's what we largely do up and down the country. So how are we doing with ultrasound surveillance in the UK? So you're probably all aware that Tim Cross did a survey back in 2016, and we repeated a survey in 2022, which many of your centres will have responded to. I took the opportunity to add some questions about how we were delivering the imaging component of surveillance in this. Overall, centres reported compliance with the NICE guidance, as you would expect. They've highlighted the ongoing issue with poor data capture, which is again something I think that we've talked about already and will address in the future. From an imaging perspective, there are quite a few issues that we can hopefully address, and we hope this guidance document will address, which is the first thing is about the variable examination coding. The practice in imaging department is pretty variable, performed between specialists and generalist operators with a lack of standardised training. Structure reporting was very much reported to be preferred by all our referral base, but very inconsistently implemented. There's a heterogeneous approach to a compromised ultrasound examination due to some of the uncertainties about what to do in that circumstance. And of course, there's no routine audit or quality assurance of how we do ultrasound surveillance or how ultrasound surveillance is performing in HCC surveillance. So I proposed to Mukti and Graham, Stuart's predecessor on the expert advisory group, that we put together some guidance engaging with the relevant stakeholder organisations about how we should be delivering ultrasound surveillance in the UK. We reached out to, of course, all the relevant clinical groups. Delighted to have some colleagues from the sonographic and imaging community here, as well as obviously I think plenty of hepatologists and liver nurses. And I'm really grateful to all the people who contributed so much time to this process, in particular to Monica, who was our patient representative. So we used a modified Delphi type process, although I'm pleased to say it didn't involve too many iterations over about an 18-month period. Started off looking at the scoping, meeting about what we would cover, and then worked through a series of amendments to the statements, and we've come up with 18 agreed statements in this relatively short window. I'm not going to go through all of those, but I'm going to highlight the ones I think that would be important take-homes for implementation, but they'll be published in the near future. The guidance is in its final iteration with Mukti and others for review, so that should be published pretty soon. So we split it into a few domains. The first is service organisation, and I'm not going to read all these out, but I think the one I wanted to highlight of these, which I think will be a really helpful step forward from this meeting, is that all ultrasound surveillance episodes should be requested under a dedicated imaging procedure code. I think that will really help in the future identify patients under surveillance and help us quality assure our surveillance service. So I don't know if you're aware, but variably across the country, ultrasound surveillance is booked under ultrasound abdomen, ultrasound liver, but there is a dedicated procedure code for this, which is US RLV, ultrasound surveillance for liver HCC detection. So if you have that code implemented through your PACS and risk team, you'll be able to find all those examinations. It will also help radiology team, which I'll talk about in a moment. So there are some other statements related to service organisation which are really directed at imaging teams like us about capacity and about how the imaging is organised. One thing to recognise is the more we offshore imaging away from secondary care trust, the more we need to be able to bring that imaging back into the trust, and that's something to be aware of with outsourcing, with community diagnostics and so forth. The second domain is performance, how we're doing the ultrasound. We very much decided that what would be out of scope with these guidance was how sonographers or radiologists should actually do the ultrasound physically and how we should interpret the imaging. That's covered elsewhere and as part of training. But two things I thought would be interesting maybe to touch on now or later in the day were Statement 10 and Statement 12. So Statement 10, ultrasound surveillance should be performed by an appropriately trained and experienced sonographer or radiologist. So what does that mean? It's quite a general statement. So at the moment, there isn't very much evidence for what appropriately trained and experienced should mean. Ultrasounds of the abdomen, which include the liver, are trained as a general skill amongst radiologists like myself and sonographers in the main. And because they're being booked as a ultrasound abdomen or liver in a lot of trusts, every operator can potentially be allocated those scans to do. I'm not sure that's desirable. It certainly isn't the case in other screening programs or surveillance programs. And one thing that implementing a dedicated risk code will be is that we can use a limited subset of our operators. So, for example, in my trust, when I started, we would have year 2, year 3 registrars coming through and doing 2 or 3 ultrasound surveillance scans during their 3-month attachment. Now, that for me is not a desirable way to deliver a surveillance program, and we've stopped that happening as a result of implementing the risk code. However, once we've identified the limited subset of people who do ultrasound surveillance, which may be a few or many people in any given trust, what should we offer them as part of training or standardization? And currently there are no standardized specific educational pathways or resources for operators, and unlike, for example, CT iconography, which I also do, there are no established volume recommendations. So we haven't made those, and I think that will be work in progress over the next few years. We, led by Ruth Reeve, who's a sonographer, are developing a training package which we're going to pilot in Wessex later in this year, which BUSGAR, who's the GI radiology community, have funded. And there is also a national survey, which I think we're going to put up a slide for, which is on the reception desk, where the sonographic community are surveying their services around operator practice, which I think will be really useful. I think they've had 35 responses, Hazel tells me, and if you haven't contributed, then please encourage your sonographers and radiologists to contribute. And then Statement 12, which I think is the other really important take-home. Firstly, code your examinations, and secondly, document them with a standardized structure report. So Statement 12, documentation of ultrasound surveillance examination should use a standardized structure report, including ultrasound LIRADS or equivalent classification. So most of you, or many of you, will be familiar with LIRADS as a mechanism for diagnosing hepatoma. But fewer of you, based on CT and MR characteristics. But the same organization, the American Congress of College of Radiology, also produce guidance on delivering ultrasound imaging in surveillance. And we are advocating that we use this structure. And it's a very useful document. It was updated only this year, so it's right up to date. And what this asks us to do is not just document our findings, but also come to a final categorization. And it asks us to do 2 things, which I think our liver nurses who run our service find extremely useful. The first is provide an overall category for the examination. So the first one, which will be 96% of ultrasound examinations, is negative or a definite benign finding, like this cyst. The second thing is subthreshold findings. That's a finding that's not definitely benign, that's less than 10 millimeters. And the third thing is a positive examination where you have a finding that we're not sure is benign, that's at least 1 centimetre in size, or a new clot in the vein, and people will go on mostly to have an MRI, but obviously could have a CT as well. And what it does is it doesn't just tell you what the outcome is, but also tells the liver nurses what's going to happen next, and the patient what's going to happen next. And the second thing it asks you to do is provide a visualization score. Now, you'll have all have had reports come back saying very difficult examination, etc. But until someone gets off the fence and gives it a categorization, you don't really know what those words mean, and it makes you do that. So you either have to give things no limitations, this nice, easy-to-image liver. You can see all the way through the back of the liver up to the diaphragm. Moderate limitations, where there's some compromise, there's a bit of loss of signal at the back of the liver there. all the way through to severe limitations. And I think this documentation will be really useful as we come to quality assure our services, because we can then look at whether ultrasound is performing in the way it needs to perform to provide a good service. Which brings me on to this statement. So the group felt that it was important to bring us in line with, for example, the EASL guidance and make a statement about the use of alternative imaging. Now, I appreciate this is work in progress. I don't want to get too deep in the weeds, and we're going to hear from Michael, for example, later about the Amulet study. But we felt that it was important that we should say that other imaging should be considered. But what I would urge is that whatever we're going to do, at the moment it's being done in very different ways across the country and perhaps even within organisations, and that if you're going to do non-ultrasound surveillance, it should be part of a standardised process. The ultrasound LIRADS document provides a standardised structure, or suggests a standardised structure. This is ours. If you adopt ultrasound LIRADS, you have a pathway to implement other surveillance. So this is what we do. This is the standard cycle of what happens to patients with the different ultrasound classifications. And then if they have a very poor visualization, that's the visualization C, the clinicians review the ongoing appropriateness of surveillance, and then they have 6 monthly non-contrast abbreviated MRI, which is the type of imaging that will happen in Amulet. Ultrasound, the LIRADS suggests we also repeat the ultrasound at 3 months if it's a C, just to check it really is a C in some patients. We aren't doing that at the moment, but we will consider doing that in the future in line with the new guidance. So, and the final domain is quality assurance, which I suspect we'll have a lively discussion about later in the day. But one thing I think as a community, and I hope will be an output from this meeting, is that we think about how we quality assure the surveillance we are delivering. What that could look like, there are obviously lots of options, and we can learn a lot from other surveillance programs, but I think we need to establish quality indicators for how we do HCC surveillance and the methodology for assessing these. There are lots of potential quality indicators. As you know, those are some suggestions that we could consider. Obviously, false positive recall is in surveillance, and the anxiety it causes, we've heard about that, is just as important as finding cancer, so we have to consider both sides of the coin. But Radian is the radiology training network, and Torch is the hepatology training network. Many of you members of that here. They are both in the process of conducting national service evaluations of what's going on with HCC surveillance, and I hope the data from that will be available later this year and will provide some very useful background for how we might quality assure in the future. So I'll finish up there. I'll say my conclusions. So ultrasound surveillance in patients with liver disease leads to more early detection, more curative treatment, and improved survival. I think there are opportunities to improve how we deliver imaging surveillance. We hope that the guidance will be a first step in harmonising how imaging services deliver HCC surveillance in the UK. And I think particular areas for discussion and improvement would be, enrolment and maintaining adherence, operator training and CPD, and quality assurance. And I'd just like to finish by really thanking and acknowledging the people who've put a lot of time into this work. So the development group, Mukti, Chelsea, Amajit, Kieran, NHS England, the wider EAG, and the stakeholder organisations. Thanks very much.